you will see that I'm now called Tarek. So it's a great and lovely name, but that isn't me. That is our lovely administrating tech, who is just sorted out something that's just fallen over my computer as we were literally about to go live. So my apologies. Welcome to our participants. I believe we've got Alex and Alfonso and Anita, I think, at the moment, along with our lovely panel. So I hope you can all hear me, and that you're able to use the webinar a little bit probably more competently than I am. So welcome. It's early morning here in the UK, so we're still waking up. But my lovely colleagues in Australia and New Zealand are at the end of their day, or towards the end of their day, so they're fully awake, which is good news. And thank you for joining us. And so this is me, for those of you who've been chatting with us on this MOOC, and we're delighted to host this webinar, which is the third week in our course, where we're looking at Everybody Has an Opinion. And we're hoping to add now, through the webinar, the opinion of our participants, along with our panel who've come along, who most of them are the educators within the course. So Anna is here from New Zealand, and Alan is here from Australia. And we do have Susie, who is somewhere in the background, but unfortunately Susie is also suffering from a few techie issues. And our lovely other educator, Trish Hafford-Letchfield, Professor Trish Hafford-Letchfield, unfortunately had quite a serious accident where she fractured her hand, and so she's currently in a hospital at the moment this morning having some therapy for that. So she wishes us well for the webinar, and is apologetic that she can't join live, but she will be dipping in post the webinar, listening to the webinar, and then she'll be available to take any questions. I'm also really pleased to welcome Keith, who's also there with Alan. You should see Keith on screen. And Alan, Keith is going to be speaking to us, particularly from his perspective. I'm going to let Keith introduce himself in a moment. He's under Alan's name, and Alan is pointing, so you know the difference. And Betsy, of course, our lovely Betsy, Professor Betsy Tom, and Betsy's actually up in Scotland. So we've got England, Scotland, we have Australia, New Zealand, and then hopefully with our other colleagues who've joined us as participants, they can let us know perhaps as we go through the webinar where you're coming in from, when you're putting through some questions. So really how the whole webinar is going to run is we've got a little opportunity for each of our panel members to speak from their perspective, and I'm going to allow them to introduce themselves more formally in a moment. And then once we get to the end of them kind of letting us know their thoughts on this subject, we're going to open it up to sort of a Q&A, a question and answers. So as you're listening to our presenters and our panel, please feel free straight away, if you have immediate questions, to just put it into the chat, which you should have visible, and you can type in your questions. I will be looking and keeping an eye on that. And then as they come through, if it's obvious it's a question for Betsy or a question for Keith or Alan or Anna and so forth, you could put that in a bracket if you would like them to specifically answer that, or I will throw it open to the group and we'll see who can make the best approach to that. So perhaps if we start with Anna. Anna, would you like to just say hello, welcome yourself, and give a little bit of background on who you are?
Sure, thank you. Ngā mihi nui kia koutou katoa. That means hello and welcome. My name is Anna Nelson, and I'm based in Wellington, Aotearoa, New Zealand. And my bit of background for me then is I'm a social worker by trade, and having worked specifically in the addiction sector for coming up for 22 years now. So currently working at Matuaraki. We are the National Addiction Workforce Development Centre. So very lucky in New Zealand to have an organisation that specifically focuses on workforce issues for the addiction sector.
Lovely. Thank you, Anna. That's wonderful. And Alan and Keith, would you like to introduce yourselves respectively?
Yep. Thank you, Trish. Carmel. It's nearly 8 o'clock here, so I'm starting to get a little bit tired, but that's okay. We'll wake up we'll prod each other just to keep each other awake. So I'm Alan Triffanoff. I'm Deputy Director of Programs at the National Centre for Education and Training on Addiction in Adelaide, South Australia. Pretty much we have the same sort of brief that Anna's group in New Zealand does. Even though we've got education and training in our name, we are very much focused on workforce development, and we've been doing quite a bit of work in the last few years around older people and substance use, and developing some resources, some guides, some practical, even just raising the issue about we've got an older population who are starting to experience quite a number of different issues around alcohol or drug use, but also a range of other physical and mental health issues that are sometimes related to their substance use and sometimes not. So it's a real key area of interest for us, and we're keen to do some more work in this area.
Okay, thanks Alan. Thanks. I'm Keith Evans, and just to add to the cultural mix, I'm actually living in Australia, but a very proud product of the Brecon Beacons. So Mum still lives there, and I still go there, and so my heart is in Wales. But I've spent most of my career in the drug and alcohol sector. Just very briefly, I started as a clinician at the Royal Edinburgh Hospital in the now non-existent unit for the treatment of alcoholism more years ago than I'm prepared to share. I then moved to Australia, and I have been responsible for policy and program development in the Queensland government and the South Australian government. I then had a fabulous 15 years in New Zealand, 10 of which I was the CEO of the Alcohol Advisory Council of New Zealand. And New Zealand really has a wonderful history of innovation and being at the forefront of development, not only in this part of the world, but I think globally. At this point in time, though, I'm the chief advisor to an organization called Silver Chain, and Silver Chain Group is the largest provider of in-home health and aged care in Australia. So we generally look after people who are over 65, not entirely, but mostly. And we have about 90,000 clients and about 5,500 staff. So we have everything from medical practitioners through to care aides working with us. So a little bit later, I'll just talk about some of the things that we are finding in that population. And in my spare time, I have an academic appointment at Adelaide University in the School of Public Health.
So much. Hello everyone, I'm Betsy Tom, and as Carmel said, I'm calling in from Scotland. I'm very privileged to be able to live in Scotland and work at Middlesex University in London. So at Middlesex, I'm Professor of Health Policy, and I co-direct the Drug and Alcohol Research Centre. So most of my career has been working in drug and alcohol research, mainly alcohol and alcohol policy. And this is from a background of being a sociologist, so not as a practitioner. Recently, what we've been doing is looking at how professionals can perhaps tackle some of the issues of alcohol use in older populations by using identification and brief advice approaches. So that's one of the things we've been doing. A long time ago, we also did a study on home carers and whether they could look at how older people were drinking and whether they were able to provide any assistance for problematic drinking in their clients. So these are the sorts of areas that we've looked at in our research programme, but we're also interested in how policy responds to this age group.
Thank you for that, Betsy. I appreciate that. I don't know, and I'm not sure that we have been able to resolve the technical issues for Susie. So unfortunately, Susie, I don't think we're going to be able to get the same level of volume that participants will be able to hear. So we're going to move forward if possible. And I wonder that if you could kick us off. We've been looking at week 3 particularly. You will have seen the way we have set out the week where we've had the lived experience, the survey user voice. We've also had something around the practitioners talking about some of the challenges they have in the field. And then we've, of course, had some of the policy research, which hopefully Keith and Betsy will speak to. But I wonder if we start with the practitioner voice, Anna, in terms, we've heard some of our participants talk about some of those challenges, and we've seen, obviously, Bill Lorman from the States, and we've had, of course, our friend from Brazil, Dr. Giovanni. And we've also had a very nice lady who's a nurse in Canada. And there was, to me, I have to say, a certain similarity or overlap of what practitioners were saying, which is that services aren't ready, practitioners don't feel skilled or quite unfamiliar with the area, and that they are having to, in addition to not really understanding the complications or perhaps the challenges for the individuals, they're really having to also deal with a lot of attitudinal challenges in terms of people either presenting to services or families being around to support, or indeed getting in the way. So I wonder if you'd like to just kind of give us your thoughts.
Sure. Oh, thank you. Well, first of all, I just wanted to say to our participants, as an educator who's been checking in week to week, that it's been so lovely hearing the stories from the participants about what their elders have taught them, and the wisdom and the respect that they a lot of cultures around the world that we've heard from are showing to their elders, and the wiser amongst us. I just thought it was so lovely, people reflecting on things that their elders had taught them. So I've really appreciated people sharing those stories. So from a practitioner perspective, I suppose there's a few points that I wanted to pick up. First of all, I found a couple of really good comments from a couple of participants that I wanted to start by reading and then talk about just quickly. So Maureen Colbeck was, after listening to Dr. Bill Lorman, said something very pertinent. I'm thinking about the whole issue of putting everything down to a person's age. As many participants have commented, it's vital that people are viewed as unique individuals and as a whole person. And I just thought that was really a really important point to make, because that's where we see a lot of the stigma and discrimination around what that means for older people, that people make assumptions about they're just old, rather than finding out more about what's going on. And we know, of course, that alcohol and substance use is underdiagnosed and misdiagnosed because of, I suppose, assumptions made about age. So I thought that was a great comment by Maureen. And another one I wanted to pick up on was from William Nish, again after listening to Bill. And this really made me think about the work of David Best. So William here talks about the importance of people not going back to the same temptations, because it's so easy, really, in a way, to relapse. And it reminded me the work of Professor David Best, who talks about the importance of people, jobs, friends and houses post-treatment, and how important that is, community integration or reintegration. So what his work tells us is that actually, in a way, what people have, or what intervention people have, is less important than the way they are then integrated into the community. And of course, we also have the Johann Hari Chasing the Scream book that's really given us the quote of the opposite of addiction is not sobriety, it's connection. So I really like that, and I thought that those are really important things to me from a practitioner background. So the first point, not making assumptions based on people's age, certainly. And yes, absolutely, we've got some great models for working with older people in practice, but really the importance of integration and the importance of family and whānau, as we call it in New Zealand. And one point that I thought I'd just focus on in my last few minutes is the importance of the involvement of family, which I know has been covered. But I just wanted to also mention the importance of offering support and services to family members in and of themselves. So regardless, in a way, of where their loved one with addiction-related problems is at on their journey, now we need to recognise that the people that surround the person with addiction-related problem also need support. And I'd like to put in a chip in for a couple of models that we're currently implementing here in New Zealand. One is from Australia, from the Bouverie Centre there in Melbourne, which is the single session family consultation, which very briefly sort of does what it says in the label. That is, at least let's be having at least one family session if we're working with, in this case, an older person. And also a great model for working with family members in and of themselves is developed in the UK, and that's the 5-step method. And I must say, I was talking to Richard Velleman this morning, Betsy, and he said to say hello from him. So the 5-step method is a very simple 5-step framework where we're offering support to the family members for looking at their ways of coping and dealing with addiction in their family. So those were the main points I thought I'd pick up on in the few minutes that I had from a practitioner perspective. I suppose that the last one would be, as a social worker, that I'm really clearly seeing here in New Zealand anyway, a move away from very medical models of practice, and we're much more likely now to be making sure we're clear about social determinants of health and looking at people very holistically in terms of the support that we're offering them. As a social worker, it's not far enough down the line as far as I'm concerned, but it's certainly moving in that direction, which I'm really pleased to see. So I'm happy to answer any questions, or I know, of course, Carmel, you've got a practitioner background as well. So.
No, I do, absolutely. But I'm just also, because we were a bit delayed, I think you've actually covered quite some, central points there, Anna. And thank you. All right. No, that's wonderful. Thank you. And I'm just going to remind our participants to have questions if they have, just to put those into the chat box, and we'll come back to them, because hopefully we'll, having heard from Keith now and Betsy in a moment, we'll tidy up and we'll come back to a Q&A, and the panel can kind of have a more discussive approach to this, with hopefully some questions or comments from our other participants. So thank you for that. Betsy, I'm just wondering if we move to the policy side, and I know that when we were preparing for the webinar, I think your immediate reaction to me was, but there is no policy, Carl. And I think that maybe that's where you're going to start. But I think that as a policy queen, particularly in alcohol and particularly more widely in AOD, you'll have a perspective on at least lessons learned from other parts of the alcohol and drug field, and perhaps other demographics. And that we can learn from some of the policies that have gone before that might influence our thoughts and ideas about what the policies perhaps should be and what we can be doing to be lobbying around that. So I'm going to hand it over to you and see whether you, unless you found a policy that we've missed. So Betsy, over to you.
No, Carmel, I haven't found a policy, and I'm not sure we've got an awful lot to learn from existing drug and alcohol policies either. So what I'm actually going to do is to pose an awful lot of questions which I think the participants might like to chew over and consider, related to, should we have a policy which is to do with substance use and older people? And if we are going to have one, What level should it be at? Do we need a national policy that covers everything, a local policy, or in fact do we need organisations to look at their policies and think about older people and substance use? So the other question that's related to age, and Anna's brought this up very nicely, the idea that there are assumptions about age. So do we need age-specific policies? Or do we need age awareness in all our policies? Or do we need to embed awareness and responses to older people in all our generic services? So all of these are policy areas that we can be thinking about to see whether they are sensitive, the policies are sensitive to older people with substance use issues. So the issue is that what about this age factor? If you look at research, and here's one example from a study, it said, for the purposes of this report, an older person is someone aged 50 and over, as this was the lowest threshold of eligibility for treatment in the older people's services that took part in this study. So what this point makes is older, if it's 50 and over, we can go 50 to 95. And can you have any policy that can be satisfactorily applied to such a wide age range? So that's one particular problem. And if we think about alcohol as an example, if you take age as a key factor, and this is what is happening in other policies, you say at age 50, people should be drinking less. What is that less? Is it 11 units, which has been suggested, as opposed to 14 units for the adult population? And we have to consider those sorts of issues. Is 14 all right for the 50-year-old, but not for the 90-year-old? So we need to think about what we mean by that. How useful is age as a cutoff, or should we think about aging as a more progressive approach, because it allows flexibility to think about what is relevant throughout the aging process, so we don't have these cut-off periods. So age in itself is a problematic concept when you think about policy. Then we've also got to think about what kind of policy, because there is a mixture of prevention, early intervention, harm reduction, treatment. So what kind of policy do we want? What's most suitable for older people? Or do we need aspects of all of that? As I said, we were doing research on early intervention, but more and more older people apparently are running into trouble with drug and alcohol use. So there has been discussion in the alcohol field of whether you should lower the levels for older people or for consumption, but it is, as I said, not based on any evidence and hasn't gotten into policy so far. Now, looking at the comments that people have been doing on week 3, there was a very nice one. It said, I think we can learn from hearing the stories of older people's experiences of substance use. It's a way of respecting and valuing their experiences. That directs us towards thinking about the user voice. Older people know what their experiences are of substance use. Policy needs to listen to what they have to say. They need to think about, well, there are a lot of problematic issues, but why do older people drink? They enjoy it, like everybody else. So if policy only concentrates on the negatives, refusing to recognise that there are positives for older people as well as for all the rest of us, then it's going to go down a route that older people might reject. So there is a need to look at positive as well as negative experiences of the use of substances. Policy as well can have negative effects. We think we're doing good, we want to do good, but policy doesn't always have positive effects. So again, one of the comments from a participant in week 2 flags this up. This participant was speaking about CAT and how policy has been passed to make CAT illegal. The participant said, since the ban, it's been expensive for older people to get hold of CAT. But since it's been part of their tradition for centuries, They would rather sacrifice some basic needs in order to get hold of a stimulant. So here we find policy which is well-meaning, may do a lot of good for some people. For some sections of the community, it's not good. There needs to be a subtle recognition of that as well. And the final bit that I've been picking up is that when we talk about problem use, there is a lot of stigma surrounding alcohol use among older people. There's compounding stigma. So a lot of older people who use harmfully are also unemployed or facing unemployment. And one report from Drinkwise Agewell had this to say: it sets out the specific barriers and challenges which are faced by the over 50s. It said they often suffer multiple levels of stigmatization due to their age, history of alcohol problems, and employment status. There's a need for central and local government, employers, and the third sector to address these barriers now in order to prevent alcohol-related harm in the over 50s population in the UK. So here the issue of stigma and valuing older employees or valuing older people is of something we need to look at. And a final comment from the Glasgow Centre for Population Studies was that the needs of older people are no different from adults more generally. So in thinking about what policies at whatever level, we need to not ghettoise older people and put them into a special category, because they are just like the rest of us. So what we need to think about: do we need policy to address early intervention in this group, policy to assure appropriate support and treatment, and policy to reduce stigma and barriers to help seeking? And how can that best be implemented at the different levels we work in? So that's it. It's not there.
No, but lovely, very thought-provoking questions, I think, Betsy, and thank you for that. I also wondered whether, given there's been a shift, I believe there's been news just come out yesterday about Scotland being the first in the world to charge minimum for a unit of alcohol, which is a massive policy shift. And as a global leader, I wonder what your thoughts are, just given that that's such a current piece of news and it's a policy sort of issue, whether you think that that's in any way going to influence particularly the demographic we're talking about as well.
Right, I was at a meeting yesterday, so I missed this. I'd forgotten about it. There's been a long battle, as you know, in order to get that, and there'll be a lot of cheering and hat throwing now that it's actually been passed. Will it do any good? The truth is, I don't know, and I think it has to be closely monitored. It may lower consumption. The theory is that it will sort of prevent problematic drinking in some of the heaviest drinkers, or go some way towards that. But I think it remains to be seen. The theory is also that it will impact perhaps on people in the lower socioeconomic groups where they are drinking heavily. It could have unequal effects. Again, what I said about policy not having equal effects across the board could apply here. Some people may be negatively affected by that. So I think we need to monitor it extremely carefully. I hope it'll do some good.
Lovely, thank you, Betsy, and good luck to Scotland with that, because we'll all be watching, no doubt. So thank you. Keith, if I may bring you in now on this, and for your own perspective, unique, as you say, multicultural, given your own background, so I'm sure there's going to be some richness in that, but specifically maybe you're going to talk a little bit about your perspective from Australia. Thank you, I'll leave.
Yeah, look, thank you very much. So in the 8 minutes or so, can I just respond to, I mean, look, it's always incredibly difficult to follow such talented presenters and with such rich knowledge as Anna and Betsy. And so I'll do the best I can, but bear with me in that regard. In fact, it's really interesting that since the UK has in a sense, split up in terms of its governance structures, that it happens to be Scotland who's been fighting a battle with the Scotch whisky distillers and the drinks industry about whether it's legal for them to introduce their new laws around minimum pricing. And it's Wales where the Welsh Assembly has announced it intends introducing minimum pricing. But the English Parliament, which started this movement under David Cameron, is the one that's backed away from it. So it is interesting to see how differentially you'll start to see some changes occurring in some parts of the United Kingdom that will inevitably impact elsewhere. And we will also watch with great interest what happens with the Scottish policy change. What I want to do is not so much talk in a sense from the perspective of my experience in the alcohol and drug field as my new experience over the past 5 years of working for an organization that by no means sees itself as having specialist expertise in that sector, but deals with people in their own homes. So if we look at Australia as a country, about 75% of people over the age of 65 own their own homes. It's a really high home ownership rate. And what we know about these people, this group of people, is that fundamentally there are two places they don't want to be. They don't want to be in hospital and they don't want to be in aged care facilities. They want to be in their own homes. And that is adding a new dimension to the question of, well, how do you deliver appropriate care? How do you access people to get information? How do you work with the families and so on? And so at the back end of what I'm going to say, I'm going to talk about a technology that we're using that I think does have relevance to the addictions end of the business. I'm really drawn, the older I get, and I suspect it is a factor of age, to the Japanese approach at the moment, and they have a strapline that says work to 80 and live to 100. And I think that's the reality for many people, is that we are working longer, we are living longer, but we are living frailer. And so, yes, the medications will keep us alive. My dear mother will be 90 on the 13th of January. She lives in her own home in Wales, on her own. And that's where she wishes to be. I will be cut out of the will if I attempt to move her into an aged care facility. And so it's a really interesting phenomena that we're experiencing as our staff are going into people's homes on a daily basis, that when we do begin to address some of these sort of quote-unquote social issues, the reactions we get when we talk about things like alcohol consumption. And that is really broken down into a couple of different ways that people respond. For many, and we've done a fair amount of internal research to help inform us here, many many women say, I spent a lifetime in an environment where I was not permitted or encouraged to drink. My husband has now died, given that men die somewhat earlier than women, and I am now taking advantage of something that was not available to me in the past. And I don't take very kindly to you telling me that I should be careful about this. It is something that I see as adding some quality to my life, and a bit of sort of leads into or attaches to some of the things Betsy was saying about, you know, our rights in a sense to be able to do the things that we choose to do in our homes and in our lives. The other side of it for us, though, is that the two largest dangers, issues for our client population are falls, as you can imagine, as people get older, falls and injuries from falls, and medication errors, both of which we find are fairly significantly impacted if there is excessive consumption going on in the home. And so whilst we don't have a policy about alcohol, other than that we will address it, we will ask the questions, we will draw out as best we can what it is for happening for people, we do so in an environment in which the policy of the country overall in aged care and in healthcare is consumer-directed care. And so the role of the person going into the home as expert and determiner of what it is that is important or not important to people is being turned on its head. The money that people have now to purchase care is in the hands of the individual. It is no longer in the hands of the state to the same extent. It's certainly not in the hands of the provider. And so there's a whole new, there's a different way of interacting, of communicating, of setting up a transaction between the people we're seeing than would have been the case even 12 months or 18 months ago. I think one of the other things that's, because it's a rare opportunity to talk to you all, one of the other things that's really important from us is that the healthcare system generally, including aged care, has not changed dramatically over a very substantial period of time and has not opened itself up to new ways of doing business. And so the whole sort of changes occurring in other markets and other aspects of our lives is simply not the case. Just a couple of data points for you from Australia. 75% of people say that they would like to die at home. With the exception of Perth in Western Australia, where the figure is about 80% of people do die at home, the figure is about 14%. Around about 14% of people get to live the last chapter of their lives as they would choose to live the last chapter of their lives. So that's a really important issue, because for many people and for their families around them, the consumption of alcohol can be a real factor in terms of coping with very, very difficult times towards the end of life. So 75% say they want to, and about 14% do. I've looked at the British data. I've got to tell you, it's not that different in terms of where people are dying compared to where people would like to die. And the WHO are doing a lot of things around that. Around about 30 to 40% of people who get admitted to hospital for acute episodes and indeed for alcohol poisoning and a whole range of other things don't need to be there. They can be treated elsewhere. They can be cared for elsewhere. But the systems just don't exist to do that. So in the last couple of minutes, I just want to talk about something that is called EMMR, E-M-M-R. And this is a product of ours that we have developed with the lovely people at Microsoft. And so if I can just take a minute to talk about that, if it's okay. So what EMMR is, it's a mixed reality system. Effectively, what happens is that we pop a pair of glasses over the front of a person's face, and it looks like, so it will be like an extension of my glasses. It's called a HoloLens. And with that, we can then have a clinician, it can be a doctor, a nurse, a social worker, an occupational therapist, at a remote distance, teleport into the person's home and sit there with the person doing assessments in real time. So it's a 3D image, it's a 3D of me, it's as if I'm sat in your home talking to you. What this does is it deals with a couple of things. One is, for many older people, they can't get out to your clinics, they can't get to your group sessions and so on and so forth. Also, they want to have their family involved. This is an opportunity to both have the family involved because they can sit in the room while the teleportation happens. But if it was, if you live 1,000 miles away across the other end of Australia, you can watch this interaction on an iPad. So you can know what it is as a family member that is happening. This technology we will roll out in March 2018. It's ready to go. Its major problem in the UK, I'd have to tell you, is you have a very much less effective bandwidth than we do here. So that when I was back home in June, it was almost impossible for me to get a line out to talk to somebody without going to the top of the local mountain, and then I could do it. Here, it's somewhat better, and it will always be an issue that you need enough bandwidth to do this, but it's a fabulous system for bringing competence, external competence, into my home, but on my terms. I'm the one who's sitting there, you are talking to me, and we can have that interaction. This is just an example of, we believe that in order to provide almost any range of services to older Australians and older populations, we have to radically rethink the way we do it at the moment and break the system. It's not easy, and there's a lot of pushback, but just wanted to share that with you. I'm really happy to send you, and I can do it at the beginning of December, not far away, I can send you a video that you can share with your with the people who are part of this movement and so on, of the actual the activity occurring. We have the video, I just can't share it until we've got it locked in at this end. So I just wanted to say that I think this is a crackingly important area, but I do like Betsy's comment about, well, have a real think about, is this a policy issue? And do you need something that's special for people simply because they are older?
Yeah.
Because we're all getting older, and we want policies that we think will be both good for us from a health and social perspective, but also that we can enjoy those things in life that actually do give us some pleasure.
Thank you, Keith, and thank you for sharing with us this groundbreaking, it really sounds groundbreaking technology. I would be absolutely excited to see it, because I think obviously its application, notwithstanding how you're applying it, but that sounds like it could be amazing in many, many other disciplines, different areas. I mean, interestingly, just as a connection, one of our professors here at Middlesex in our department, Professor Rena Papadopoulos, has teamed up through a Horizon 2020, which is a European grant funding scheme, with Japan and Italy, and they are currently developing robots, Pepper the robot, who will be going into care homes and working with older people in care homes. And Rena's particular specialty and area and discipline is transcultural, cultural sensitivity and transcultural communication. And she is doing all of the work on that project about how to make the robots culturally sensitive in the way they will be communicating with the older population. But I think that, you know, it's really getting quite exciting, I think, in terms of, you're absolutely right, we haven't, telemedicine has been around, and certainly we've seen it from, say, acute medicine point of view, of people going in and being able to diagnose or ring in or have blood pressure cuffs attached to telephones, so you get that remote telemed. But I think there's something very, very difficult at the interpersonal level to engage with somebody in a meaningful way from a distance. So this technology you're describing sounds like you may at least have gone some way to cracking that, which is just sounds remarkable. So I would love you to share that, and I'm sure the participants would love that as well. So thank you for that. I think that I know Susie has been doing some messaging. So thank you, Susie. I'm spotting you making some comments on the side. I'm also aware that we have some of our other participants. They're either a little shy or maybe you're just happy to listen. But I would invite you now, if you have any specific questions you may have for Keith or Betsy or Anna or myself, we'd be very happy to take any specific questions. So please just put those into the chat and we'll take them. In the meantime, I just wonder, having listened, Anna or Betsy, whether you want to come back on anything that you've heard or have any specific question. I see Brian is just starting to type to us now, so thank you, Brian. We'll wait till that comes through. But in the meantime, Betsy, Anna, have you anything, or indeed Alan? I know that you're very kindly hosting Keith in your office, but please feel free to jump in because you're very knowledgeable in this subject, and I'm sure you'll have some thoughts.
Okay, thanks, Carmel. I might hand over to Anna and Betsy first because they've already spoken. So if they want to respond to anything that Keith just said, or if they want to add anything else,
wonderful,
thank you. To chip in after.
Betsy, Anna?
Well, I just really wanted to, I know that Susie can't be here, but I just wanted to acknowledge her as part of this project because she is our lived experience person, as well as being a social worker and counsellor. And I work with her, even though we live in different cities in New Zealand, I work with her, and it's a shame she can't be here because she is, you know, absolutely fascinating and incredibly interesting, having lived these two very different lives of addiction and recovery. And I just really wanted to acknowledge her, and you know, she can keep writing down the side there if she wants to, but just to let people know that we have had the service user voice of lived experience has really been an important part of this project. And I know, Betsy, that was really important in what you said in terms of policy and, of course, as well in practice. So yeah, I think that's really important, and just as from a workforce development point of view, that is our major co-design process when we develop resources and training. Always has led by a lived experience, really, and that's mostly Susie, I have to say. Yeah, so I just thought I'd add that.
And thank you for surfacing that very strongly, because I think, and hopefully people have been able to also engage on Susie's blog. We've made a link to that, and I think, if you haven't checked out Susie's blog, we really recommend you do so, because apart from it being extremely well written and witty, there is some real wisdom within that, and I think she brings alive the service user voice in a very nice way, actually. So just direct people to that. And I see Susie is still chatting away with us, so thank you, Susie. We know you're there. Betsy, if I may, because I can see that Alfonso, one of our participants and one of our colleagues here, but he's raised, which I think is an interesting one, and you may have already felt that it's addressed by saying we just have to play the watching game with the new policy in Scotland. But I think Alfonso makes a good point, where they've raised the price of cigarettes as a public health measure to try and put people off smoking. It not necessarily has worked, because of course I think we say in the UK that for every 5 cigarettes smoked, 4 are illegal, i.e. that people are bringing it in without tax. So I'm not, I just wonder whether, making such good, it seems good steps, and I'm not sure what else one can do, but I just wonder, it's a good point, isn't it, that maybe just raising money on or levying tax against something doesn't necessarily equate with a good public health policy.
Yeah, well, I was a bit cautious, because obviously on a day when public health people are celebrating, it might not go down too well to say, I'm rather sceptical of the whole thing. So, I was playing myself with everyone. But I agree with Alfonso, and that's what I meant by saying it can impact quite unfairly and unequally on different parts of the population. Although lower socioeconomic groups drink less, they suffer more from alcohol-related harms. And so it is quite possible that, just like the cat quote that I gave you, that people who are drinking heavily and not necessarily dependent, but perhaps dependent on alcohol, will spend more of their income on the alcohol to continue to drink and deprive themselves of food. So that is something that we have to have a look at. And it is possible that it will perhaps encourage people who don't drink that much to drink a bit less, but have not the same impact on
Anna, your response in the chat that you feel it's worked to a certain degree, along with other ideas, but Anna's suggesting in New Zealand there has been some impact by a price increase. So maybe it's where it's delivered. Yeah.
Yeah.
Alan, do you want to come?
Well, that was just in regard.
Oh, sorry,
And that's the same.
Sorry, Alan.
Sorry, yeah, Keith and I were just looking at each other, because I think in Australia that's certainly been the case, echoing what Anna was saying, where smoking rates have decreased substantially. But it's been more than just price increasing. It's been a whole range of policy initiatives and public health policy initiatives, education, banning advertising, all forms of cigarette advertising, plain packaging. So there's been a number of different initiatives.
Yeah, just to follow up on that one quickly, it's the classic, I think smoking is the classic example of a public health policy around the 3 Ps. If you can attack price, promotion, and product, then you're starting, you've got a pincer movement. One on its own is not likely to be that effective over time. But if you've got the 3 coming, where you've got the advertising controls and the price controls and the age going up of consumption and so on, it's a classic example of, in the context of Australia at the very least, and New Zealand, a phenomenal change to smoking rates, particularly amongst young people, which is where people wanted to target it. But Alfonso's right in terms of as a standalone, it's unlikely to have an impact. And again, you know, I'd have to say that if you look at the things that the industries, whether it's tobacco or alcohol, the things that the industries support are likely to the ones that are least effective in terms of affecting their bottom lines. So the ones they're most concerned about implementing are the ones that I think they well recognise are likely to have the most.
Thank you.
Can we just
Sorry,
point
Betsy,
out
go ahead.
that consumption? I was going to say that consumption is falling in the UK, consumption of alcohol, and particularly among young people. We don't exactly know what's brought the fall about, but it is an interesting trend that's been going on for quite some time now.
We've had the same with our National Drug Strategy Household Survey, which is a biannual, two-yearly biannual comprehensive population survey. We found the same thing, that alcohol use amongst younger people is falling, but where it is increasing is amongst the over 60s and over 65s, and particularly amongst women as well. That's a trend that we've been seeing over the last couple of years, and that's been certainly borne out by the last results that were made available, I think, in September of this year. So it's a similar, echoing a similar situation to what Betsy was saying. And you'd be well aware of the BMJ editorial that Anne Roach and Tony Rao from the UK put out back in August, that got published in August and attracted substantial media attention both in the UK and here as well, because of that consistent finding.
Sorry, Anna, we may have missed that. We've got about 3 minutes, and I'm just thinking we're moving into the 4th week of the MOOC, which is about getting back up again. We're using our pun on falling down quite a bit, but we're going to be getting back up in terms of our focus, which is sort of what works and what treatment works. So just reminding our participants that that's what week 4 is about, because I think what I've discovered, and I'm sure the other educators have, is that, there is some people who are starting to feel a little bit despondent in the commentary about, oh my goodness, this is quite a challenge. And I'm just kind of reminding us that, we do know what works in actual fact. I think that that's one of the things that's been amazing in addiction over the last, at least 10 to 15 years. We've made great strides in terms of what treatment works. I mean, obviously, we're going to be focusing it in the 4th week around that age group. And I go back to Betsy, there is some things we need to take into consideration when it comes to age, but I think that we do know, in effect, what works now, both in psychosocial interventions. We know an awful lot now with medication, what's good, what doesn't work. So I think that next week, when we start to get into that debate and start looking at the material, I just wonder, in the last sort of 30 seconds each, what would be your take-home message from the webinar? So if I give one to each of you, that might just take us nicely up to the 10 slot. So Anna, as the person to have spoken, what would be your take-home message?
Just going on from what you said, Carmel, I suppose going into week 4 is that as practitioner, from a practitioner's perspective, there is always hope. And our job is to hold the hope where it's lost anywhere else. And we do know that recovery can happen and does happen. It lives in the community. It's all around us. And just hold the hope, because we never know when, the corner's going to be turned and someone's going to, move into recovery, whatever that might mean for them.
Thank you. Betsy?
I'd like to build on what Alan said, and said we all need to promote consumer-directed policy and practice, because I like your model.
And Alan and Keith.
Thank you. I'll start off and then Keith can have the last word. I just wanted to quickly reiterate the quote that we use in our guide that was developed by the Centre for a Practical Guide for Health and Welfare Professionals about working with older people. And it's from Betty Friedan, and it says, "Aging is not lost youth, but a new stage of opportunity and strength." And I think going forward to the next weeks, the last 2 weeks of the from the
Lovely.
MOOC
Thank
is
you, Alan.
bear
Thank
that
you.
in
The
mind.
last word.
Well, look, just to reiterate what Betsy was saying, at the end of the day, people don't lose their capacity as they age to understand their environment, the things that impose risk, and the ability to trade off risk against reward. And we need to understand that, and we need to work with that, because in that way we will help people to both monitor their lives somewhat more successfully, perhaps, but also to
That's
live
a very
life
lovely
to the
sentiment
fullest.
and really very nicely rounded off. I appreciate that, Keith. I appreciate everybody's participation. Thank you so much. It's been really very, very enjoyable and amazing that we can do it across all the different continents, which is fantastic. I loved that. Thank you so much, and thank you participants for hanging in there. And we look forward to hearing your responses perhaps on the commentary section that is in the Keep On Learning or directly in the MOOC section. And as others are listening, perhaps they'll listen outside of time, outside of the live. We'll hopefully have a little bit more debate, so keep an eye on the commentary. So thank you, everybody. Have a lovely evening over there in New Zealand and Australia, and have a lovely day up in Scotland, and best wishes to everybody else. Thank you so much.